Alright, so previously we left off right here. We did this, well actually no we did. Yeah, we did that question and we did not do this question. Right, so NBME 22. I was just watching the YouTube Rewind this year, YouTube Rewind 2019. Sadly, very disappointed to find out I'm not in it, but it was pretty good. It's much better than last year's. In case you guys didn't know, YouTube Rewind last year was the most disliked video on YouTube. So YouTube Rewind 2018 was pretty trash. This year's YouTube Rewind 2019, significantly better. They did a good job. They apparently satisfied a couple more people. Of course, you're always going to have some people that are complaining, but overall, they were able to satisfy most viewers. I gotta see if I ever make it to 1 million subscribers, or if any of my videos ever make it to 1 million views. That would be a new milestone for me. Alright, so anyway, enough of that. We'll find out how big I get whenever I get big. So here we are now, NBME 22, Block 3, question number 121. A 12-year-old boy is swimming in a mountain stream. He's immersed up to his neck in 60 degrees F water for 20 minutes. Which of the following sets of physiologic changes is most likely to occur in this boy? Right, so now I will say that the temperature they picked, all you know is that it's not freezing, but it's also not that hot. It seems like pretty normal temperature, right? It's not that he's in really cold water, nor is he in really hot water. So I didn't like that they chose that as a temperature. It could have been, yeah, this is supposed to be C, right? Yeah, could have been anything else. But I don't know. They went with what they went with. So the this is supposed to be a question on hypothermia. So the physiological response to hypothermia is vasoconstriction of peripheral vessels, which are the ones that are in your fingers and other extremities, in an effort to keep your core body temperature normal. Okay, so you're going to try to do vasoconstriction, and thus your organs will be able to function properly while you are able to keep yourself warm enough. Peripheral vasoconstriction will increase central blood volume, right? Because remember what vasoconstriction always does. If you do vasoconstriction, less blood stays in the vessel and it gets sent out to your organs. Increased central blood volume will cause an increase in preload. Okay, and this will increase your AMP and BMP, because remember AMP and BMP. So we're looking at let me see. We're looking at this line here, right? So increase, decrease, and increase. So AMP increases anytime you have high volume in your heart, right? So that's always good to remember. So an increase in preload is an increase in volume in your heart. Preload is how much blood you put into the heart. ANP and BNP have inhibitory effects on the renin-angiotensin-aldosterone system, which would thus decrease your ADH. Okay, so that was just answer choice C. How you would think of this, to be honest, is kind of weird, because when I was looking at this question, remember that every time I do NBME explanations, I often do the questions myself first, then I check for the correct answer, and then I put whatever happened, right, the explanation. So when I did this question, my initial thought was, that he must be in water that's colder than his body. That's kind of what the theory here is. So his body is obviously going to be warmer than 60 degrees F. So being in colder water than his body is kind of like being in cold water. If you're in cold water, you're going to have more central blood volume. Okay, so you can knock out E, F, G, and H. You're going to have more central blood volume. You will do, vasoconstriction. And when I started this question, I first said that you would do vasoconstriction because you're going to constrict to send blood to your organs. The point is, if you do vasodilation, think of the opposite. If you do vasodilation and you have a lot of blood at the surface of your fingers, and you go into cold water, you're just going to lose all of that heat. You're going to lose all of that heat. So you do vasoconstriction, send blood away, and send it to better places where it'll stay hot. right? Don't keep the blood in your extremities, because if you do that, you're just going to lose all of it as heat, right? That's the main concept here. So I was really between any of these answer choices where ADH is low, and of course, whenever you do that kind of vasoconstriction, blood stays in the organ. So blood stays inside the heart. If blood stays inside the heart, you're going to release more ANP, right? And central blood volume will be high also, because vasoconstriction means blood stays in the body, right? Not in the vessels, but in the organs instead. So central blood volume. So pretty interesting way to ask such a weird conceptual question, but NBME likes doing silly stuff like this. I honestly don't think this is how a medical question should be, but they can do whatever they want to. This one, 10 healthy human subjects are given a new oral drug and monitored for drug effect and toxicity. Blood samples are periodically taken and analyzed to define the human pharmacokinetics of the drug for the first time. Which of the following best describes this trial, right? Now, they did put in a bunch of shit into the question, but the main things you care about are the fact that, first of all, it's 10 subjects, right? Second of all, they're healthy, right? They're healthy. They're not patients. And you're testing for effect and toxicity. Okay, those are the things that kind of help you figure out, what phase you're in. So if you go back to the part where they talk about these phases, I would say, I think it was right here. Yeah, no, not that one. Where do they talk about that? Let's see. Phase. Yeah, clinical trial. This is public health sciences, epidemiology, and biostats. Oh, okay. Epidemiology and biostats, right. So phase 1, when I talk about this page, I'm surprised I haven't written it here, but usually you wanna think of the fact that all of these phases, the number of people that are in them is 10 raised to that power. For example, phase 1 will have about 10 people. So that's 10 raised to the 1. Phase 2 will have about 100 people, or 200, or 500, any 100. So that's 10 raised to the second power, right? 10 squared is 100. Phase 3 usually has a very large number. It's usually with a whole hospital or something really big like that. So that's 10 cubed, right? 10 raised to the third. That's 1,000 or 2,000 people, and so on. Phase 4 is pretty much infinitely large, okay? So 10 raised to the fourth works here too, 10,000, because this is post-marketing. So now it's basically out in the world. You're giving it to patients, you're prescribing it, and you're basically watching if something that didn't occur so far to anyone else occurs to one of these patients, okay? Now, what happens in phase 1 specifically? Phase 1 is healthy volunteers, right? And you're just checking if it's safe. You're checking for safety, toxicity, pharmacokinetics, pharmacodynamics, just like our question explained. Uh, 256. And what was the 262? Okay. Right, so that's something that you can easily always catch. Now, if in a question they don't give you the number of patients, that's when it becomes slightly more difficult, right? Because then you have to think of all the other things that are being checked in terms of the purpose column here, right? If they don't give you the number of people, how many people are in there, then you have to work based off of the purpose section. So phase 1 is safety, phase 2 is work, right? This swim mnemonic, okay, it works pretty well. Phase 3 is improvement, and phase 4 is market. So when you're checking for whether or not something works, for it to work, you have to work with sick people. So you take patients, right? Patients with disease. For safety, you can give this drug to anyone, any human, whether or not they're sick or healthy. You can see how toxic the drug is, how the patient metabolizes the drug, and so on and so on, right? But to see if it works from the swim mnemonic, the work part has to be in sick people. Okay, so patients with disease, and then improvement requires using a large number of patients, right, to see if this drug works better than the current standard of care. And the only people that would be taking the current standard of care would be found in a hospital or a clinic, right? Such a population where a lot of people are being treated for something. Right? So using the swim mnemonic to memorize everything is a little better than trying to memorize everything based off of the number of patients. Right? Safety, and then how many people you would have to check. Work, what kind of people and how many people you have to check. improvement, how many people you have to check, and then market is just market. It's out there now. It's being given to everyone, and all you're checking for in the market aspect is something that might not have occurred to any patient in one of these phases. Right? Oftentimes, some medications have weird interactions with another drug that none of the people in these trials must have been taking. Okay, so now you'll find out that, oh, I had a patient who I gave this drug of yours to, and that patient was also taking maybe warfarin, and your drug has a weird side effect with warfarin. So now that information will be given to the pharmacological company. They're going to utilize that and publish it and make sure everyone else taking warfarin knows about that. This was pretty easy. So, a 32-year-old woman comes to a physician because of a one-day history of chest pain that radiates to her left arm. She also has a 1-week history of swelling of the left eye and a 4-day history of recurrent episodes of fever followed by shortness of breath, muscle aches, and joint pain. 2 weeks ago, she returned from a trip to the Amazon rainforest. Her temperature is 102.4, pulse is 110 per minute, respirations are 17 per minute, and blood pressure is 90/65. Bilateral basilar crackles are heard over the lung fields. There is 3+ edema of the lower extremities. Photomicrograph of the peripheral blood smear is shown. Right, they gave you a bunch of shit in this scenario, and not only did they do that, they also went ahead and gave you this image here, right, which they're showing you the bug. Now, NBME loves having questions on all of this stuff. They have a lot of microbiology questions, some bacteria, but they also go a lot into parasites and nematodes and all of that other stuff. So be ready. Right now here, this was E. This is the reduvid bug. What they're describing is actually clinically shown in the book. Right, so let's go ahead and take a look at it. Chagas disease. No, it's in microbiology, bro. Right, I think it was called the Romania sign. Yeah, like this. Right, this is actually how the patient is presenting. Right, that's what's happening to her. So let me put this here too. Right, they tell you she has swelling of the left eye, and well, it just so happens that the picture I have has swelling of the left eye. Right, so this kind of swelling thing, and then they describe you muscle aches, shortness of breath, and joint pain. Right, Amazon rainforest, pulse is high, respiration, blood pressure is low, bilateral crackles, right? Something's happening to the heart. All the symptoms they gave right here, this one, the bilateral crackles in the lung. Bilateral crackles in the lung in this patient is actually due to left heart failure. Blood is backing up into the lungs now, right? And then 3+ edema, another sign of heart failure. Why? Because Chagas disease causes dilated cardiomyopathy. It's one of the C's of ABCCCD. Right, so unilateral periorbital swelling, that's the Romania sign. You can have any of these things: dilated cardiomyopathy, megacolon, megaesophagus, Amazon, South America, right? Fecal transmission into bite site or mucosa. Right, so not so bad. Now, this is something you also have to be careful for. It is fecal transmission. Okay, that would be the correct answer choice. But a lot of times when you see fecal transmission, you're like, all right, no one's eating poop here. And then you just completely ignore that answer choice, which is totally understandable. But this is, and you know Chagas disease comes from a kissing bug. So you don't associate that with fecal transmission, but it is. Right? The triatomine insect bites and defecates around the mouth or eyes. And that fecal transmission into the bite site or mucosa is what leads to infection. And the image they gave you is a trypanosomal, right? Very similar to the one is in your book too. Right? So that's Trypanosoma cruzi. Not so bad at all. What is this? This is page 158. Okay. And then I also listed out what the other arthropods are, so you do really need to know all the other bugs that are involved. So oh, by the way, these ABCDs are not related to the ABCDs here. I'm just listing out all the bugs and stuff you need to know, and you can see some of them right here. So our answer choice for Trypanosoma cruzi reduvid bug, which is answer choice E. E is the correct answer here. Okay. All right, another GIT anatomy question. So they love this. They love GIT anatomy on NBME, and so does Step 1. Step 1 likes it as well. A 2-day-old full-term female newborn suddenly develops biliosemesis, abdominal tenderness, and hemodynamic deterioration. An upper GI barium X-ray shows the ligament of Treitz on the right side of the abdomen and duodenal obstruction. This patient is at greatest risk for occlusion of which of the following arteries, right? So you do need to know your ligament of Treitz. You need to know the general, outline of how your entire GIT anatomy looks like. So you can see your ligament of Treitz right here, and that's the ligament of Treitz labeled. Now, if you see it on the right side, right, that's a problem, and that's actually midgut malrotation due to improper positioning of the bowel on the right side. Lad bands connect the large intestine to the liver. Any of this can lead to volvulus, duodenal obstruction, or supramesenteric artery occlusion, which is answer choice D. Right, your supramesenteric artery, which is after the celiac, supramesenteric artery can get stuck while all of this flips over. Okay, so this anatomy is something that does often get tested. Midgut malrotation is also in first aid, so let's go take a look at that real quick. GIT, search for malrotation, yeah, right here. So this is what they're kind of talking about, right? So you see your lad bands, right? Your entire small bowel is on the right side, and then your colon is on the left side. This is a weird thing that can occur. It's not supposed to be, it's not normal, but it can definitely occur, and it can lead to volvulus or duodenal obstruction, right? Improper positioning of the bowel and lad bands. And there's more about this as you go on too, because then you have volvulus, right? Now volvulus is different. This is a midgut volvulus is different in kids, and it's different in adults. In elderly people, you get a sigmoid volvulus. And sigmoid volvulus is what they're showing you in the book. Okay, so your entire colon kind of got really big, and your colon's on the right side. Midgut volvulus is more common in infants, and it looks like this. Okay, so that's the image I'm showing you over here. And you just need to know that it's going to be the supramesenteric artery just because of the anatomy of where things are. Okay, supramesenteric artery is involved in a lot of things. The answer is almost never celiac or inferior mesenteric artery for questions like this. Okay, this one, 56-year-old woman comes to the physician for a follow-up exam 8 weeks after recovering from pneumococcal pneumonia. X-rays of the chest show no abnormalities. Which of the following most likely allowed this resolution to occur, right? So basically, how did everything resolve? And this was a pretty tricky question because, increased angiogenesis was what I picked. I picked answer choice B, so I got this wrong. And this is C, yeah. And so what allowed everything to go back to normal was the basement membrane integrity, okay? Basement membrane integrity is the determinant of full lung recovery following a pulmonary insult. And here's a summary thing I found online. So loss of basement membrane integrity is critical in determining the point of no return and contributes to the inability to reestablish normal lung architecture with promotion of fibrosis. Loss of epithelial cells, endothelial cells, and basement membrane integrity in usual interstitial pneumonia or idiopathic pneumonia, fibrosis, right, associated with idiopathic pulmonary fibrosis, leads to destroyed lung architecture and perpetual fibrosis. The phrase usual interstitial pneumonia or usual interstitial fibrosis is also used in another NBME. TGF beta is necessary but not entirely sufficient to promote permanent fibrosis. Persistent injury, antigen, or irritant is critical for propagation of fibrosis. Idiopathic pulmonary fibrosis is an example of a process related to persistence of antigens leading to chronic inflammation and fibrosis. Unique cells are critical cellular players in the regulation of fibrosis. Right, so loss of basement membrane. Basement membrane integrity is a very big deal for understanding resolution versus point of no return. And that's what this question was trying to teach you. 31-year-old man comes to a physician because of concerns about hair loss. He has a family history of androgenetic alopecia. Examination shows some hair thinning over the vertex with normal scalp skin. If pharmacologic treatment is elected, use of a drug to block the synthesis of which of the following steroids is most appropriate. Now, almost 99% of people immediately chose dihydrotestosterone, right? And that is, why do I keep doing this? Excuse me. And that is why this question is a very easy question, but also a very high yield question. You need to remember finasteride, okay? Gotta remember finasteride. When people come in for androgenetic alopecia, you give them finasteride. Finasteride is a 5-alpha reductase inhibitor, which is also used for BPH, but there's a smaller dose, and the name of the medication is called Propecia. The smaller dose of that medication is for male pattern baldness. The newest discovery was, though, that lately you no longer use finasteride. If you are going to use it, you have to advise the patient that it can cause potentially permanent sexual dysfunction. Okay, and once they acknowledge that and they sign the waiver that they don't care, then you can go ahead and give them finasteride or Propecia for the treatment of their male pattern baldness. But in general, right, that's the pattern. Androgenetic alopecia is due to dihydrotestosterone, too much DHT. And it's also the same thing for patients with PCOS, right? Females who have PCOS will have high amounts of testosterone, which often gets converted to dihydrotestosterone, and you can start seeing male pattern balding in females as well if they have PCOS, as well as hirsutism upon many other things. This one, yeah, this wasn't so hard at all. A 44-year-old man comes to the physician because of fever and mild abdominal discomfort for the past 3 days. He has a 10-year history of IV drug abuse, right? And that's a big giveaway. IV drug abuse basically means that it's venous, right? It's in the name, venous, so you're injecting blood into your veins. So injecting drugs into your veins. Temperature is 102, so he has some kind of infection. Blood pressure is high. Liver is palpable. Prominent systolic pulsation of the liver, which is really weird, right? Systolic pulsation of the liver, like what are they even talking about? Which of the following is the most likely diagnosis? So you don't need to worry about anything else they're saying. Don't get thrown off, don't get intimidated, don't get confused. It's just a patient with a 10 years, very extensive 10-year history of IV drug abuse. You're most likely going to see tricuspid insufficiency, right? Because IV drug abuse plus right heart failure symptoms like congested liver all are signs of tricuspid insufficiency. All of that stuff that you're injecting into your veins comes back to the right heart, and the first valve they encounter, all the pathogens in the blood, the first valve they encounter is your tricuspid valve. The other answer choices are completely irrelevant. Renal artery hypertension, portal systemic shunt, hepatocellular carcinoma would be another possibility later on, but that's not what this question is about. Remember that hepatitis B and hepatitis C are very high yield for step 1. Hepatitis B is usually related to sex and unsafe sex and STDs. Hepatitis C is the one that's related to doing drugs, IV drug abuse. Okay, and hepatitis C could cause hepatocellular carcinoma in our patient. However, that's not what our question is currently about. But they really caught a lot of people off by, mentioning this systolic pulsation of the liver, right? This is such a weird way to mention this. You don't have systolic pulsation of the liver. I don't know why they would say it like that. I don't know if it's even correct to say it like that. You have systolic pulsation, and it's near the liver because it's the tricuspid valve. It's on the right heart. Other than that, it's not really a pulsation of the liver. Your liver does not pulsate. And this wasn't a dissecting aortic aneurysm either. That would just present with a lot of pain, not just mild abdominal discomfort. A 17-year-old boy comes to the physician because of a 1-week history of fever, fatigue, and sore throat. His temperature is high. Physical exam shows an erythematous oropharynx, bilateral cervical lymphadenopathy, and splenomegaly. Lab studies show a leukocyte count of 15,000, 50% typical lymphocytes and 10% atypical lymphocytes. A test result of heterophile antibody is positive, which is pretty much a diagnostic. 12 months, 12 months after his complete recovery, which of the following is still likely to contain the virus that caused his sore throat? This is not... What? Right, so how do you figure out what's happening here, right? This is Epstein-Barr virus. You know Epstein-Barr virus immediately because of the heterophile antibody and the fact that he's pretty young, and this is pretty common in this middle, high school to early college age. Usually spread just from making out with people and whatnot. So, and the symptoms, right? Fatigue, sore throat, fever, splenomegaly, lymphadenopathy, mainly bilateral cervical lymphadenopathy, all of that. So what happens in this is that you infect B cells, right? And keep in mind, one of the other really common questions you often get about Epstein-Barr virus is, what is that atypical lymphocyte? The atypical lymphocyte, what is it? So an atypical lymphocyte in Epstein-Barr virus is actually a reactive T cell. The B cells all look normal. They don't look like, they're dying or exploding or anything like that. But the T lymphocytes are reacting to this viral infection. So all the atypical lymphocytes they're talking about, that 10%, those are reactive T cells. Okay, so very important to remember that. They always, UWorld has a very notorious question on that topic as well. So let's take a quick look at that. No. Maybe if I search for bar. Yeah, right here. Right, so you can see this kind of image can be given to you, right? So the left one is a normal lymphocyte. The right one is atypical. It's not a normal looking lymphocyte. If such an image is given to you and they ask you what is that atypical lymphocyte, they explain it to you in first aid. Atypical lymphocytes on peripheral blood smear are reactive T cells, not the infected B cells. Infected B cells look normal. Okay, this is different when you go to HTLV, right? T cell lymphoma. In T cell lymphoma, if they gave you the same image and they ask you what the atypical lymphocyte is, in T cell lymphoma, it is the cancerous T cell that looks atypical. Okay, so that's the little difference that they love bringing up. Also keep in mind, if a patient comes home because they have mononucleosis and the mother sees all these symptoms that look like, the baby's just, their kid is just sick, and they give the kid amoxicillin would cause a really weird maculopapular rash. It would be the wrong treatment, first of all, right? But maybe you thought they just have normal strep pharyngitis or something, and you gave them amoxicillin because you have some sitting at home. Well, they're going to end up having a really weird rash, and on top of that, their mono won't go away. Okay, so be very careful with that stuff. And Epstein-Barr virus is latent in B cells. When you do your viruses, remember all the latencies, okay? It infects B cells and ends up staying latent in B cells. It can come back again when you get sick. You also need to remember, basically all the herpes viruses are very capable of being latent, right? So HSV1 is latent in trigeminal. HSV2 is in the sacral ganglia. Right? You got to remember that because those are things you can easily get questions on. HHV3, varicella zoster, is in the trigeminal, right? And you remember that because this is how it reactivates, trigeminal style, and so on and so on. So latent in mononuclear cells, CMV, right? And then HHV, this one, they don't tell you any more latencies here, but you don't really need to worry about them too much. They're not that high yield. HHV8 is very critical for AIDS patients. This one is just kids, right? Roseola fever first, rosy rash later in kids, roseola infantum. Right, pediatric rashes. Okay, 27-year-old man comes to a physician for a routine examination. He smoked 1 pack of cigarettes daily for 14 years. When the physician initiates a discussion on smoking cessation, the patient says, I'd like to quit because I know it can hurt me in the long run, but I'm not ready to take such a decision now. Which of the following most appropriate next step for the physician? Right, so what do you do next? And remember, most appropriate step questions, the ethical ones, you have to make sure that you don't do something where you're pressuring the patient, you're intimidating the patient, or you're being rude to the patient, none of that stuff. So A, ask the patient to identify the pros and cons of smoking cessation. B, detail the long-term health effects of smoking. Initiate pulmonary function tests, prescribe bupropion, recommend nicotine replacement therapy. Okay, so now, how do you pick, which one is correct? Because yeah, he says I'd like to quit. He did say I'd like to quit, but I'm not ready to make such a big change now. He doesn't want to make the change yet. So basically, he doesn't want to quit right now. He wants to quit, but not right now. Since he does not want to quit right now, you definitely do not prescribe bupropion. You won't recommend nicotine therapy because he's not asking you for any of these recommendations. No reason to initiate pulmonary function tests. I think the easiest answer is to eliminate here words C and D. B, detail the long-term health effects of smoking, or ask him the pros and cons of smoking cessation, right? Because C, D, and E really don't make sense. You're not going to do any of that. He's not asking you to. it's better to ask him for what he understands before you start detailing the long-term health effects of smoking. He didn't come to you in the clinic for a lecture, right? Long-term health benefits of smoking, health effects of smoking. So ask him, because he said he knows, right? He said that I'd like to quit because I know it can hurt me in the long run. So let's find out what he knows. Ask him, what do you think are the pros and cons of smoking cessation? Right? What would be the benefit of quitting? Basically, what would be the harm in going on? Those are both the same question. All right, so remember the OARS acronym, OARS, open-ended questions, affirmation, reflection, and summary. Reflection is telling them back something, or making them say something back, that kind of thing. This OARS thing, you can find more about it online. Very important to understand. This is how a physician is supposed to, discuss certain topics with the patient. You use the OARS mnemonic. Open-ended questions, affirmation, reflection, summary. Question 130. A 39-year-old woman comes to the physician because of increasing hair growth on her face for the past year. She has not had a menstrual period during this time. A CT scan of the pelvis shows an ovarian tumor on the left. Serum testosterone concentration is 450, which is significantly higher than normal. Which of the following lab values is most likely increased due to the increased serum testosterone concentration? Right, so which of these things would be high because of the high testosterone? So, you think of testosterone and all the things it's capable of doing, and people who actually would abuse testosterone for stuff, and it's just hemoglobin. This is kind of like doping. She's self-doped, right, because of her tumor. The ovarian tumor is probably what's causing her to make too much testosterone. Testosterone is an androgen, and it does have erythropoietic stimulating effect. Right, so she might have polycythemia because of the high testosterone. The other answer choices just don't make any sense. PSA would definitely not be high. You can definitely cancel that answer choice out. HDLs are the good lipoprotein, and there's really no reason for that to be elevated due to high testosterone. FSH and alkaline phosphatase, right? Just irrelevant. FSH is a follicle stimulating hormone. It has nothing to do with testosterone, right, in a female. So the answer here was just C. Hemoglobin would be high. Testosterone causes polycythemia. Not polycythemia, hematopoiesis, which, if you have extensive amounts of it, will lead to polycythemia. Alright, so that's half of it. Now, during a study of the symptomatic proximal DVT, patients with this condition are randomly assigned to receive either dalteparin subcutaneously for 5 to 7 days, and then oral warfarin for 6 months, or dalteparin alone subcutaneously for 6 months. No placebo controls are used. The probability of recurrent thromboembolism at 6 months is 10% in the dalteparin group and 19% in the warfarin group. Which of the following best describes this study design? Okay, so now you really need to know the differences between each one of these very, very well. What they did here, right, with no control, there's no control, right? There's no placebo control being used. There isn't really a control per se at all, right? Because there's no one that's doing pretty much nothing. They're both kind of doing something, and they're doing different things, and you're going to compare it. So you can cancel out case control, that's for sure, right? Then you're left with case series, observational cohort, open label clinical trial, or open label crossover study. A crossover study would have them kind of switch places now, right? Because that's what the crossing over is. There's a little waiting period where the effects wash off, and then you would switch the groups over. So the group that was only doing dalteparin will now do dalteparin then warfarin, and vice versa. This is definitely open label, right? Because open label, both the health providers and the patient are aware of the drug being given, and it is a clinical trial where you're comparing therapeutic benefits of 2 or more treatments, like warfarin versus dalteparin. So this was just D. Right? Very important to know all the different case studies, and when you find more case studies, you should put them into the book. Right? It helps you remember them, because like case series, for example, this one right here, right? You can see we're doing NBME 22 right now. Case series is an answer choice here. In NBME 20, case series was actually the correct answer. NBME 20 discusses a question about case series studies where demographic information like age, gender, ethnicity, and information on the diagnosis, treatment, and response to treatment are followed over a period of time, which makes it look very cohort. Okay? And that was a really interesting question where they chose patients simply based off of age, gender, and ethnicity, nothing else. Now, if they were sick or whatever. And then they just followed them and saw how things went. So that was case series, very unique kind of thing. Never really heard of it before until I saw that question, right? And the more questions you gather and learn about, the better it gets. This one is also this is the one that we just did right now, NBME 22. So I put that here, and yeah, that's about it. A crossover study. Let me show you. This is how a crossover looks like. This image right here, right? And you see how the crossover requires a placebo, and then they switch places. Our study design didn't have a placebo, so it's not a crossover. Right? So knowing that there's no placebo control, you can definitely knock out A and knock out E easily. Right? Observational cohort, you have to remember there's a very specific thing about it. It checks relative risk. Why? Why do you do cohort calling? You remember cohort, remember spelling cohort like this, okay? Don't spell it the normal way, spell it with 2 R's so you can remember the relative risk aspect. It compares a group with a given exposure or risk factor to a group without such exposure. It does not compare treatments. It does not compare treatments. That's what you have to remember. Cohort is not for comparing treatments, it's for comparing risk, right? Relative risk, the risk of smoking. Smokers had a higher risk of developing COPD than non-smokers. That's something you discover from a cohort study. This is not a cohort study because here, yeah, you're checking for risk of something, but it's not from disease or something bad. It's just which treatment works better. And checking which treatment works better is a clinical trial, not a cohort study. Right, so that kind of little technicality stuff, you don't want to let that get in your way of picking the right answer choice. So be very careful with that. A 5-year-old boy is brought to the physician because of pain in the right eye at night for the past week. There is no family history of neoplasia. Examination shows strabismus and tenderness in the eye. The left eye is normal. Examination of the retina shows the presence of a mass. The physician explains to the patients that the boy is unlikely to develop any other neoplasm. The first mutation leading to this neoplasm most likely occurred in which of the following? Right. So if he's not going to get any other kind of cancer, but he does have some kind of retinal mass, and where do they write that? Tenderness, left eye is normal. Yeah, the retina has a mass, right? So if the retina has a mass, but he's not going to get any other kind of tumor, that means that his DNA is okay. Whatever occurred must be in the retinal cells, right? Just B. Very silly kind of question. The physician said that the boy is unlikely to develop any other neoplasm, so he doesn't have the inherited retinoblastoma mutation. In this case, he has sporadic retinoblastoma. Sporadic retinoblastoma requires 2 somatic mutations of retinoblastoma in the same retinal cell. Just as a side note, inherited retinoblastomas tend to be bilateral. Sporadic ones are unilateral, like our patient. Retinal cells are somatic cells, but that would not be specific, right? Because some people wanted to pick somatic cells. But somatic cells of the child would, somatic cells encompasses many somatic cells, not just the retinal cell. The specific cell that this kid has an issue with is the retinal cell. So B. Right, very interesting way to ask such a question. Not nice at all, because of course a lot of people got this wrong. People were confused. But at the same time, it's also easy depending on the mind map you took while you're reading the question. Right? Something's wrong with the retina. No other cancer is going to be present according to this genius doctor. So the issue must just be in the retinal cells. Bone tumors again, right? So this is a pretty high topic in NBME. We've already done 2 bone tumor questions in the same NBME so far. 78-year-old man comes to the physician because of a 3-month history of increasingly severe back pain that is worse at night and persists regardless of his activity level. Physical exam shows no abnormalities. His serum alk phos is increased. X-ray of the spine shows numerous lytic lesions along the vertebral column. Which of the following is the most likely diagnosis? Right? And they were kind of, oh, well, no, I was going to say they were kind of nice to you by not putting prostate cancer, but I guess by putting this metastatic carcinoma answer choice here, they weren't exactly nice to you, right? Because a 78-year-old man with back pain and, metastasis to the back, you would assume is because of prostate cancer. And the only way to get that correct would be to figure out if it's supposed to be lytic or not, right? Because then once you figure that out, you can pick C. But if it's not supposed to be that, right, then it's not going to be C. And this is something we talked about in the last video too. So let's go back and take a look at that real quick, because there was a bone tumor, not a bone tumor question. In the last video, there was a prostate cancer question. Prostate cancer is pretty high yield on NBME. So let's take a look at that. No, bone. Yeah, it's right here somewhere. Okay. Bone. Yeah, this graph. So we took a look at this graph last time too. This is very important to know. There's only 3 of the guys that would ever have osteoblastic lesions, right? Let me just make sure. Yeah. Okay. How do I present this? Put this down here. Okay. So there's only 3 things that have osteoblastic lesions, and that's prostate cancer, small cell lung cancer, Hodgkin lymphoma, right? And here, although they tell you that the X-ray of the spine is showing numerous lytic lesions along the vertebral column, looking at the other answer choices, the reason I'm bringing this up again is because a lot of people were very bothered by this question. Metastatic disease is more common than primary brain tumors, and we don't have sufficient information to really pick any other answer choice. But this metastatic carcinoma that we're talking about most likely must not be from a prostate cancer. Okay, that's the thing that I'm trying to get at here. Because you would think prostate cancer, and then you would pick back, you would think, the prostate cancer is what's causing his vertebral column cancer metastasis, but it's most likely not. Okay, this guy most likely has some kind of other cancer that metastasized and caused him to have osteolytic, right? Because he has an osteolytic. So just keep that in mind. Because if the answer choice here said metastatic prostate cancer, then that would not be the correct answer anymore. Right? But metastatic carcinoma, it could be another thing. Maybe he has multiple myeloma or non-small cell lung cancer or renal cell carcinoma or a melanoma. He could have any other issue. One of those other things is what caused the lytic lesions. So keep this graph in mind, right? And especially keep in mind just the osteoblastic part. Everything else has some osteolytic in it, either mixed or completely osteolytic. But osteoblastic is unique to prostate, small cell lung cancer, and Hodgkin lymphoma. The non-stuff is osteo, non-small cell, non-Hodgkin, melanoma, RCC, multiple myeloma. So how do you cancel out other answer choices? Osteosarcoma, chondrosarcoma, and Ewing are malignant bone tumors, but none of them are related to back pain or vertebra per se. Osteo has Codman burst, the Codman triangle thing, and occurs in young males. Chondro occurs in the pelvis or legs, and it's more cartilaginous. And the Ewing occurs in kids, right? Pelvis and legs, and has onion skin periosteal reaction, and small blue cells, and the 1122 translocation. So all 3 of those wouldn't really fit this patient. Then osteitis deformans Paget disease, right? That thing has lytic and sclerotic lesions. It alternates between many things, right? ALP would be high, but this usually has AV malformations and long bone fractures, right? Osteitis deformans. AV malformations often lead to high output heart failure in these patients. Our guy doesn't seem to have any of those other issues. He just has metastasis to the back, okay? And that metastasis to the back is the main problem with this guy. He's got to deal with it. He's going to need treatment. So that's it for that part. Okay, here. 48-year-old man comes to the emergency department because he is vomiting blood. 6 months ago, he had a 3-month hospital stay for severe alcohol-induced pancreatitis. His recovery was complicated by a pseudocyst of the pancreatic tail that required surgical drainage. Examination shows splenomegaly, hemoglobin concentration is low, platelet count is 56,000. Which of the following vessels is most likely thrombosed? So, alcoholic, right? He's an alcoholic. Now he has pancreatitis. And there's a problem with the pancreatic tail, right? Complicated pseudocyst of the pancreatic tail. UWorld has a bunch of questions on pseudocyst thing, so be ready with that too. Make sure you know what the pseudocyst is, how to differentiate it from a pancreatic adenocarcinoma. And he has splenomegaly. His hemoglobin is low, platelet count 56,000. What would you pick? So just as a random fact, in patients with pancreatitis, the most likely vessel for thrombosis is the splenic vein because of how close it is to the pancreas, anatomic ties. This would also cause gastrosplenic varices, explaining the vomiting of blood. And it also explains the splenomegaly. If you have a thrombosed splenic vein, the blood will pool in the spleen and can also cause expansion of red pulp of the spleen. Right? None of the other arteries really or veins really makes sense to pick. In fact, picking any vein doesn't really make much sense. You wouldn't pick veins. You would not pick any veins. So that kind of knocks out half the answer choices. What am I saying? picking any artery wouldn't make sense. Okay, picking any artery wouldn't make sense because arteries, right? You have to remember where you really get platelet thrombosis. Arteries don't really fit the scenario for this stuff. All the arteries are going to be working just fine. Arteries are also usually stronger than veins are. Veins are very weak. So when the thrombosis occurs in a vein, right, and that's the answer here, splenic vein. When the thrombosis occurs in a vein, that leads to excessive bleeding because veins are very weak. They burst, they rip, things go bad. And this guy vomiting blood, that's a portal systemic thing, right? And anything portal is usually portal vein. So you knew you had to pick an answer with the vein, but it wouldn't be. So that next I'll have the answer choices: gastroduodenal artery, pancreatic duodenal artery, left gastric artery, and splenic artery. Now, the four options you have: left gastric, splenic, pancreatic duodenal, and gastroduodenal. If you remember where they are on the stomach, right? If you remember where they are on the stomach, then you could just pick the correct answer just based off of basic anatomy, right? So if you have your stomach, right, you need to remember where everything goes. So if they tell you gastroduodenal and inferior pancreatic duodenal, those guys are in this area over here. That wouldn't be correct. Your left gastric artery. So you have to remember the left and right gastric artery, right? The left gastric, right gastric, and then you have your left gastroepiploic, right gastroepiploic, right? Those guys, and then up here, by the way, for the stomach, it's kind of more like that, right? So up here, you also have the short gastric, right? Short gastric, and the short gastric one comes from the splenic. You need to remember that anatomy like super well. You should be able to completely redraw that anatomy anytime you get a question about any of those things, because it's a pretty high yield topic. In fact, the entire thing with the branches of the celiac artery are very high yield. So let's take a look at that real quick. Celiac, this thing, right? So fit width, okay. Right, so you see your left gastric, your left gastric gives you this entire thing here and some esophageal branches. You have your right gastric, which comes off of the common hepatic, and short gastric and splenic. You see the pancreas in the back, it's outlined. So the pancreas, you can see here, the pancreas is pretty much going along with the splenic artery here. The splenic vein is also in the same area. Let's look at the veins. So you have your veins here now, this one. You see the splenic vein, right? Same kind of thing, just like the splenic artery. But the venous supply is the special thing in GIT, because look at how cool this looks. Right? This is the whole venous thing with your portal system, the hepatic portal vein. Right? You have your portal vein, you have all the different branches, the way they go. Keep in mind that the inferior mesenteric vein is actually a branch of the splenic vein in the portal system. And then your superior mesenteric vein is just a continuation of the hepatic portal vein. So this outline is very important. These are the guys that often get injured and can pop and burst and cause many problems. Not necessarily the arteries. Very rarely do you ever get a question where the arteries burst. The only time you get a question about the arteries bursting is if you have an actual ulcer in the stomach. Right? An ulcer in the stomach is acidic. That can easily go ahead and just shred through anything. So the artery will easily burst, and that would be problematic. That would really suck. Right, so gastrosplenic varices, very interesting question. It makes a couple points. It teaches you a couple things, but very easy to get this wrong too. A lot of people were just very confused as to why it would be splenic vein versus splenic artery. And if you had a burst of the splenic artery, by the way, you wouldn't really see splenomegaly, right? Because what does the splenic artery do? It brings things to the spleen, right? And then the splenic vein is the one that burst because of the thrombosis. So what does the splenic vein do? It brings things back from the spleen. It's not able to. So whatever went into the spleen is now staying in the spleen. And that's one intelligent, simple way to just think of, would it be splenic artery or vein? And that's it. 28-year-old man, recurrent pancreatitis associated with familial hypertriglyceridemia. Administration of a drug with which of the following effects is most appropriate? Okay, so hypertriglyceridemia, so the patient is going to have high amounts of triglycerides, right? How are you going to fix that? So administration of a drug with which of the following is most appropriate, and you would just need to be decreasing VLDL. How would you figure that out? Well, for one thing, it's a good thing that they tell you it's hypertriglyceridemia and not like, oh, it's type 2 or type 3 hyperlipidemia or anything like that. Um, in general, 1 in 4 are the ones that have pancreatitis and high triglyceridemia. 1 has xanthomas and creamy turbid supernatant in plasma, while 4 has insulin resistance due to the adipose. 2 and 3, type 2 and 3 dyslipidemias, have atherosclerosis and high LDL. The even numbers are autosomal dominant, type 2 and type 4. Below are the root pathogenesis of each and what's mainly in the blood. Right, so 1 is due to LL or C2. C2, remember, is a cofactor for lipoprotein lipase. If you're missing either one of those two things, you end up having type 1 dyslipidemia, where you're going to find chylomicrons and triglycerides. Type 2 is a deficiency of ApoB100, which is necessary for LDLs. Type 3 is a deficiency of ApoE, so you can remember that as 3, and the 3 letters again, LDL. VLDL is related to type 4, right, which is the triglyceridemia, with recurrent pancreatitis and all that stuff. And you would just have to give them any medication that would help lower the VLDL, right? Triglycerides too, that's another thing you'll try to lower, but reducing the VLDL is the more significant part. And they obviously didn't put both answer choices here, okay? You're definitely not trying to increase anything. Increasing HDLs is not necessarily a treatment for any of these issues, even though HDL is a good thing, but you're not going to increase chylomicrons or phospholipids. That's pointless. So you can definitely knock out C and E, and you can knock out D. You're between A and B, and VLDL is the main issue with that. So let's take a look at it in the book real quick. It's the last thing you discuss in metabolism. And you need to spend a little bit of time to really like get it down, drill it into your mind. Your dyslipidemias, type 1, 2, 3, and 4. The memorization tool that I just mentioned in the last page is pretty helpful, but you have to memorize the memorization tool also, so it takes some time. But yeah, hyperchylomicronemia, cholesterolemia, dysbeta-lipoproteinemia, and then type 4 is the one that's called hypertriglyceridemia. That's the one that has the VLDL stuff. You got to treat them with something that can lower their VLDL ASAP, as well as triglycerides like fibrates. A newborn born at 26 weeks gestation has respiratory distress and requires intubation and maximal oxygen support. Another high-yield topic that's often found in NBME. A chest x-ray shows a ground glass appearance in both lungs, which is a giveaway for neonatal ARDS. Deficient synthesis of which of the following is the most likely cause of the respiratory difficulty in this newborn, which is really easy, right? So it's just not enough surfactant. Unfortunately, surfactant wasn't an answer choice, so you had to pick dipalmitoyl lecithin. Remember, there was a lecithin to sphingomyelin ratio, and the more important guy is the lecithin. It's the thing that you definitely need. The sphingomyelin is also important, but that's not the guy that you need a lot of. Right? Remember this graph. So you see how much lecithin you need, the red line? You don't need that much sphingomyelin. You do need it at this point, at the 30-week point, but you need a shit ton of lecithin to make good surfactant. If it doesn't happen, then you're going to end up with neonatal respiratory distress syndrome, which has the ground glass appearance of the lung fields, right? And you can treat it, but the treatment is another thing that is problematic. Therapeutic supplements to oxygen can cause many issues: retinopathy of prematurity, intraventricular hemorrhage, bronchopulmonary dysplasia, all of which are a no-no. You don't want any of that. You don't want any of that in your kid. So here are just 3 URO questions that are also relevant to the same topic if you want to check it out. And just remember that lecithin is also called dipalmitoyl phosphatidylcholine, right? And they call it dipalmitoyl lecithin, right? So it has many names. It has a couple names. Just be ready. URO also had a question with the same graph, but it wasn't labeled. And it's pretty important to remember that lecithin is the guy you really need, okay? To make surfactant. This is the second weird anatomy question. NBME loves anatomy questions, like musculoskeletal anatomy questions, and oftentimes they can get pretty weird. They won't be the typical anatomy questions you're used to seeing. So here they tell you a 27-year-old man is brought to the emergency department 2 hours after injuring his left ankle while rock climbing. His pulse is 80 per minute. Respirations are 25, blood pressure is a little high. Physical exam shows swelling on the medial and lateral aspects of the left ankle and severe pain on palpation. right? So he definitely did some kind of fracture on his ankle. An X-ray of the ankle, the left ankle, is shown, right? So they're showing an X-ray of the left ankle. You're looking at it right here, right? And I made the two black circles. They weren't there. I made the two black circles to show you what you need to focus on. The patient's injury most likely occurred when his left foot was forcibly moved into the extreme of which of the following positions. Okay, so they're basically asking you which one did he do. Did he do this one or did he do this one? That's basically all you're coming down to. Excuse me. So, pretty weird question. It's really hard, to be honest. It's really hard to figure out whether he did the lateral ankle injury or the medial ankle injury. And, even after studying it for a while and taking a look at this explanation, I'm not entirely convinced. So, because there is avulsion fracture on the medial side from the deltoid ligament and fibular fracture on the opposite side, this is classic for an eversion. The answer here was B, right? Eversion. So you see the medial side, the lateral side, you have your tibia, you have your fibula, right? And this is the left leg, okay? So what you're noticing in the bigger circle here on the medial side is that medial side is that you have an avulsion fracture, right? That's that break right there. Okay, so let me get my pencil again. That's the crack that you have right here. That crack is the avulsion fracture they're talking about. So because that occurred, this patient had an eversion injury like this. Medial ankle injury. They gave you an x-ray of the man's left leg and you are looking at it from the front as usual. This man had a medial ankle injury. So his lower fibula is broken and his tibia is cracked entirely. Right? The lower fibula being broken is the thing. It's lower fibula, not like that. It's not cracked vertically, it's cracked horizontally. So let's take a look at how the opposite thing would look. How would the other guy look? So if you had a lateral leg, sorry, what did I click on? If you had a lateral ankle injury, right, with an inversion issue, that would be like this, right? The image is shown here telling you what would happen. And you could see the x-ray here, right? So you see how, and this is the right foot now, so it's the right leg, so you're seeing the fibula on the opposite side. You can see how the crack, is not really affecting much of the tibia. The tibia is okay, right? It's the fibula that really gets the majority of the break, but the tibia is okay, right? So I guess the takeaway for such a thing would be, especially if you're trying to go into orthopedics, the takeaway would be that if you do an inversion, right, you invert your leg, right? Remember, this is inversion, eversion. If you inverted your ankle like that, you would actually end up cracking only the fibula. Okay, but if you did a eversion injury, that would crack both guys. You would crack the tibia, and by everting into the fibula, you would crack the fibula too. So yeah, definitely a weird question. I didn't get this right. I put inversion, so I didn't know what to do with it. But that's why I made sure I found a bunch of x-rays and images to be able to explain it and understand it myself. Yeah, pretty weird stuff, but that's NBME. Two patients, a 54-year-old man, patient X, and a 76-year-old woman, patient Y, are about to receive IV vancomycin for severe gram-positive bacterial infection. Okay, both patients weigh the same. Patient X has an estimated GFR of 60, and patient Y has a GFR of 20. Right, so it seems like patient Y might not have a good kidney. Which of the following parameters of their drug therapy is most likely to be the same in both patient X and Y? Right, so pharmacokinetics, super easy stuff. Pharmacokinetics is just one page. It's just one page in first aid. And you can spend an entire day on it if you really need to, but it's pretty straightforward. So here you look at all your answer choices: elimination half-life, loading dose, serum concentration at 12 hours, which is related to elimination, and time to steady state concentration, which is also related to elimination. Loading dose does not change based off of how healthy a patient is. Loading dose is the only answer here that is independent of drug clearance. Loading dose also does not change your renal or liver function, but maintenance dose does. Mathematically, loading dose is target plasma concentration, volume of distribution, right, divided by bioavailability. This equation has nothing to do with clearance. Right? How much do you want to load into this patient is literally just dependent on volume of distribution, nothing else. Half-life has clearance in the denominator, and steady state is related to half-life. Maintenance dose has clearance in the numerator, right? You could put all those equations on your cheat sheet if you want to, but I said, when I made the cheat sheet, that understanding the conceptual things I already did the video on this a while ago in the full FA playlist. Understanding the conceptual aspect, especially the concept of volume of distribution, all this stuff that first aid doesn't teach, is super significant. You really need to know that, right? And then dosage calculation, you see loading dose. In renal or liver disease, maintenance dose is decreased and loading dose is usually unchanged. Okay, you don't change the loading dose. That's just how much you're putting into the patient because that's how big they are. That's how much they need. And then depending on how quickly they're able to clear it, you have to edit the maintenance dose. So that was just the answer here, B. 139. Previously healthy. This is another pretty high yield topic in in NBME. A previously healthy 6-year-old boy is brought to the physician by his mother because of a 1-week history of an itchy rash in his armpits, both hands and feet and groin. The itching is most intense at night and keeps him awake. His vital signs are within normal limits. Examination of the skin shows multiple erythematous papules, some with burrows, and many of which are excoriated, similar to the ones shown in the photograph. Which of the following questions to the mother will be most helpful in establishing the diagnosis? Right? And you know immediately when you see all these question marks that it's going to be a pretty bullshit question. So you start reading the answer choices. It says, do you have any pets at home? Now, if you didn't figure out what's wrong with this kid before starting, looking at the answer choices, then I don't know what you're going to think. But, it is Sarcoptes, right? He has scabies, Sarcoptes scabies. So scabies don't really have much to do with pets, so you wouldn't really ask A. Does anyone else in the family have an itchy rash like this? That's totally worth asking. Does your child take any medications? Have nothing to do with this. Has there been any recent travel? That's just a trick bait. It's not necessary to ask that at all. And have you changed soaps or detergents lately? This would be what you would ask if someone presented with weird rash or allergy type of reactions all of a sudden, right? In places where the clothing would be. So this is scabies, which is transmitted person to person. If no one else has it, and this has been happening for a week with this little boy who probably touches everything, then it's probably not scabies, okay? And that's why you would ask this. It's really important to figure out if anyone else has it. If the parent says that, oh yeah, my daughter has it or my husband had it, but it went away because he washed himself or something, then it's, it's scabies, because scabies is highly contagious. It just goes from one person to another, right? And that's why you would ask. If no one else has it, if this is only happening to this kid, then you got to start investigating what this could be, right? And it's going to be a little more of a big deal. All right, last question for this video. A patient in the early stages of hemorrhagic shock is most likely to have which of the following? So what is the first sign of shock? Right? What is the first sign of shock? That's what you want to always remember. And that's something that USMLE RX videos actually taught a long time ago when I did it. The first sign of shock. So let's look at 331. Sorry. So let's look at shock, right? So we have all our shocks, okay? All the shocks are pretty much the same except for the septic shock or anaphylactic shock. Distributive shock is a little weird. It has warm skin. Okay, septic shock, which is obviously very high yield, is the only one that really has warm skin because there's a lot of vasodilation and you actually treat it with pressors, right? Vasoconstrictors. In these people, their blood pressure falls down significantly. But the others, right, hypovolemic, cardiogenic, obstructive, we're talking about the hemorrhagic, so that's hypovolemic shock, okay, hemorrhage. In hypovolemic shock, what is the whole concept? So up here, I have some notes. In hypovolemic, the main issue is loss of intravascular fluid, often due to hemorrhage. Volume loss decreases preload and central venous pressure, so this decreases cardiac output. The body responds when baroreceptors recognize hypoperfusion and ramp up the sympathetic response to increase systemic vascular resistance and thus afterload via alpha-1 vasoconstriction. And now you get cold and clammy skin. Right? So that's your hemorrhagic shock right there. So if you look at all your answer choices, which one fits that scenario, it would just be E, a weak pulse due to decreased stroke volume. And this completely makes sense because even if you don't remember what we just talked about right now, that little blurb, hemorrhagic shock, you just lost a lot of blood, your stroke volume will be low, it's going to be a weak pulse. That's the first thing a patient with hemorrhage will show up with, regardless of the whole conceptual aspect of shock. But also remember, the earliest symptoms of shock is usually a decrease in cardiac output. Remember that cardiac output times systemic vascular resistance is mean arterial pressure. Hypovolemic, cardiogenic, obstructive, or distributive, they all have a decrease in cardiac output. This is why systemic vascular resistance increases to maintain mean arterial pressure. Distributive is significant because of a severe decrease in systemic vascular resistance, but practically defines it, right? So that we already talked about distributive just now, right? And distributive is pretty unique because it's the only one where cardiac output might be higher, but you want to keep septic shock in a whole different aspect of things, okay? Keep septic shock separate. It's different from all the other guys. If you did the Golgin review questions for step 1, he actually makes this point too. He'll ask you what differentiates septic shock from everything else, and it's the fact that it would have warm skin, right? Because there's more cardiac output and there is vasodilation, and you treat it with vasopressin. So, yeah, at least, yeah. Let me just put it here just for completeness. They all have a decrease in CO except distributive, septic, anaphylactic. But the other one, the CNS injury one, that does have a decrease in cardiac output. Keep in mind CNS injury, I don't know how you guys define the CNS injury part, but CNS injury is a pretty big deal. It's in cardiovascular, and then again it's in GIT too. In GIT, remember the Cushing thing? You cushion your brain. So a Cushing ulcer is basically gastritis in your stomach due to injury to the vagal nerve. Injury doesn't mean that it's dead. It means there's overactivity, right? There's too much parasympathetic vagal activity, which leads to too much acid release, and they get gastritis. That's a Cushing ulcer. The same thing we're seeing here too. CNS injury is basically only relevant systemically because of the cranial nerves that get injured. So you could think of this as excessive vagal activity here, right? So you do end up having, a low PCWP, decreased cardiac output, decreased blood pressure. Everything gets really, really relaxed. Okay. So that's it for now. We'll continue on later on. Thank you very much for joining. We're almost done. Question 141. So 2 more. 160 and then 180 and then 200. So 3 more videos and then we'll be done with NBME 22. Keep studying and then I'll see you guys later on.